morning. My name is Angelique Heimel. I'm one of the maternal fetal medicine specialists here at Mass General. I'm also the director of the Maternal Fetal Medicine Fellowship. And this morning, I'm going to be talking with you about hypertensive disorders in pregnancy, why obstetricians and cardiologists should care, and what they should care about. So I'm sorry I'm not able to be with you guys in person today, but hopefully you'll be able to learn something from this presentation, and then will be time for questions later on. So I have no disclosures. I now have gotten to the point where I feel happy about that, and I wonder if I can maintain this forever. I do want to say a quick thank you to both Jeff Ecker and Mike Green. So they are the ones who came up with the catchy second part of that title. That wasn't from me. And they also are two people from within our division who have been thinking about this problem of preeclampsia and long-term health implications for a long time. And they did offer me some of their slides since they've given talks in this kind of forum before. So this is a very big topic, and though I talk very quickly, we only have 30 minutes, so please do remember your questions, and as I said, there'll be an opportunity for questions in the question and answer session later. So here's sort of a quick roadmap about what we're going to be talking about today. So first, we're going to talk about hypertensive disorders of pregnancy and what the criteria for diagnosis really is. What are the different ones that we think about? And then what's the underlying pathophysiology, and how does that inform the way that we think about those conditions? Then we'll think through, what do we do when we find these? So what's the treatment? Is there any screening that we would offer so that we would be able to anticipate these problems before they occur in pregnancy? Are there preventative measures we can offer? And then also just thinking about the intersection of maternal fetal medicine and cardiology. Are there things that we want to think about in terms of long-term health outcomes for women who have these complications in pregnancy? So I'm going to start always with a case. Friday afternoon clinic in the setting of coronavirus isn't quite the same, but we are still seeing patients in person in obstetrics. So this is a patient that walked into my clinic. So 19-year-old G1P0, so first pregnancy. She's at 37 weeks, so full term. She has no past medical history, has had an uncomplicated course so far, and she comes in for her routine visit. We take her blood pressure, it's 150 over 100. We do her urine dipstick, which is a part of our usual prenatal care, and it's 2+ protein, and she reports that she has a severe headache. So this one sort of checks all the boxes in terms of thinking about the diagnosis of preeclampsia, but what really are those criteria and how do we think about them together? So there's a whole bunch of different complications that are interrelated and related to high blood pressure in pregnancy. So preeclampsia is high blood pressure associated with pregnancy in particular, and we can have what's called with severe features or without severe features, and we'll talk about how we make those distinctions. Then obviously we have many women who come into pregnancy with a hypertensive disorder. So they have chronic hypertension. They can have their chronic hypertension that just continues through the course of the pregnancy, or chronic hypertension is also a risk factor for preeclampsia, and so we can have preeclampsia that is superimposed upon that. And then the last category is gestational hypertension. So new onset elevation in blood pressures in pregnancy, but doesn't meet the criteria for any of the preeclamptic disorders. We'll talk more specifically about what each definition is. So preeclampsia, as I said, is new onset hypertension, defined as a systolic blood pressure of greater than or equal to 140 and or a diastolic blood pressure of greater than or equal to 90, 2 times at least 6 hours apart, along with proteinuria. And so that the gold standard for the diagnosis of proteinuria in pregnancy is 300 milligrams in a 24-hour urine specimen, but we also do use the protein creatinine ratio of greater than 0.3. The clean catch urine really comes from the WHO and from thinking about other resource settings and showing a 2+ urine on the dip. I think the most important thing that actually relates to that idea of how do we measure proteinuria is that the hypertension and the end organ dysfunction are the most important parts of preeclampsia. And so proteinuria is one element of that, but there's other ways we want to assess for end organ dysfunction. The other important thing is to think about how do we determine whether this is really something that's associated with pregnancy. So not just underlying health conditions. We're seeing people more frequently in pregnancy. Is this an underlying hypertensive disorder that we're seeing now because we're seeing the patient in the office? And so the main way that we distinguish those is based on the gestational age. So while not impossible, it's very unusual to have preeclampsia prior to 20 weeks of gestation. And we also look carefully at the blood pressure trend. So we are fortunate that even in the setting of coronavirus, we see patients quite frequently in the office. So we want to look back at their baseline blood pressures, any blood pressures from prior to pregnancy as well, and understand, were they previously normotensive, or could this be chronic hypertension that we're seeing? So in thinking about those additional complications, eclampsia is kind of one of the more severe complications that can happen with this disease. It's not clear that preeclampsia is a precursor to eclampsia necessarily. There are women who present just with eclampsia to start off with, and that's defined as a tonic-clonic seizure in a woman who has some of the other characteristics of a preeclampsia diagnosis and doesn't have another etiology for seizures. So certainly if we ever have somebody who their first presentation is a seizure, we want to think carefully about a workup to make sure that there's not another underlying condition that we need to be thoughtful about. And then another variant of preeclampsia is HELP, which is hemolysis, elevated liver enzymes, and low platelets. Again, probably related to a preeclamptic picture, but can present in a woman who doesn't have hypertension, can be in the presence or absence of proteinuria, but does also seem to be falling into the same kind of related number of disorders that come from the placenta and are cured by delivery and are distinct to pregnancy. So when we think about the definition of preeclampsia with or without severe features, as I said, that really has to do with end organ involvement. And so are you having this hypertension alone? Are you having hypertension with proteinuria, but at the level where we don't think it's having significant end organ damage? Or are you having things that seem to indicate that there is end organ involvement? So for severe features, for neurological features, we think about cerebral or visual disturbances. Headaches is the most classic, but also can have altered mental status, scotomata, or cortical blindness. For renal findings, so elevation in creatinine. So remember that creatinine tends to fall during pregnancy. So as it's getting higher, that's the abnormal. Doubling of baseline creatinine has been used as one potential criteria. Elevated uric acid is not diagnostic, but can be a clue towards this. And then oliguria of less than 500 cc's in 24 hours. For the GI manifestations, liver function tests that are twice the normal range, also presenting sometimes with severe right upper quadrant pain. Hematologically, we see hemoconcentrations. We'll see hematocrit that's much higher than we would normally anticipate in pregnancy, and also can see low platelets. And then for pulmonary signs, you can see pulmonary edema. So obviously in pregnancy, in addition to having all of the maternal organs, we also have to think about the fetal compartment. And so originally there were some fetal findings that were part of the criteria for severe preeclampsia. Now with the understanding that really the maternal morbidity and the maternal complications are the things that probably drive the management the most, these are no longer diagnostic criteria, nor are they necessarily an indication for a change in management, but are something to think about just in terms of additional ways in which we can see that this disease is manifesting. So growth restriction for the fetus, oligohydramnios, rarely intrauterine fetal demise, and then abruption, which can be seen just with hypertension, but also as a complication of preeclampsia, and is particularly important when we're thinking about expectant management. So what are the other pregnancy-related hypertensive disorders? So as we said, we can have chronic or pre-existing hypertension. And so, generally has been defined as systolic blood pressure of the same level, greater than or equal to 140, and or diastolic greater than or equal to 90, that either is documented prior to pregnancy or is present on at least 2 occasions before the 20th week. So showing that it's not really pregnancy-related. On the other side, on the postpartum, if the hypertension persists for more than 12 weeks, then we no longer consider that to be pregnancy-related. And so just like anybody with hypertension, chronic hypertension can be primary or secondary to a variety of medical disorders. And so women should undergo the same workup that you would for somebody of their same age, comorbidities, and family history. So if there is an indication to, look for a pheochromocytoma or to look for renal artery stenosis based on the way that the patient is presenting, we would still want to pursue those workups for patients who are diagnosed in pregnancy. Now, obviously, with the change in some of the hypertension guidelines and treatment or diagnosis of hypertension with a lower systolic and diastolic level outside of pregnancy, the decision that the American College of OB/GYN has made is that if a patient has been assigned a diagnosis of chronic hypertension based on blood pressures in the 130s over 80s prior to pregnancy, then we would follow the guidance for treating them during the pregnancy as a chronic hypertensive. However, if you are diagnosing hypertension during pregnancy, we would use this 140 over 90 criteria. And the reason for that really has to do with kind of the long-term outcome data that we have for diagnosis of hypertension in pregnancy, which used that cutoff. So superimposed preeclampsia, as I said, having baseline hypertension is a risk factor for developing preeclampsia. And so how do we differentiate that if it happens? So, new onset of proteinuria in someone who didn't have it before, or any of that end organ dysfunction that I described in a woman who is known to have chronic or pre-existing hypertension. And so the blood pressure criteria really would be worsening or resistant hypertension. It can be sometimes difficult to figure out because, as we know, there's physiologic changes during the course of the pregnancy in blood pressure. And so in particular, around 30 weeks is sort of when blood pressures are coming back up from the nadir at 20 weeks, and trying to sort out whether this is worsening chronic hypertension, normal physiology of pregnancy, or preeclampsia can sometimes be quite challenging. Really, the best thing to do is collect more data to try and figure out, is this really a change in blood pressures for this patient or not? And then secondly, we usually do a baseline assessment of proteinuria in the early part of pregnancy in a chronic hypertensive, so we kind of know where they're starting, and then we're able to reassess proteinuria if the hypertension is getting worse, and that can be a clue as to whether this really is superimposed preeclampsia. Gestational hypertension is sort of, a version of that just has a fewer things than the preeclamptics. And so this is, hypertension without proteinuria, no other signs or symptoms of preeclampsia. So that means no lab abnormalities, no symptoms. It's hard to tell exactly whether this is really its own disorder or whether this is just early stage preeclampsia. About 25% of women who have gestational hypertension will go on to develop preeclampsia, but there are others who don't, who just have this mild hypertension and don't develop any of the other symptoms, at least not before the time that it's time for delivery. And what we also know, and this relates again to what I was talking about lab and proteinuria abnormalities, is that women who have severe gestational hypertension, so systolic blood pressure of greater than or equal to 160, diastolic greater than or equal to 110. So their risk of complications in terms of both maternal and fetal complications, but maternal most specifically, is the same whether they have proteinuria present or not. So the hypertension and the level of hypertension, along with the evidence of end organ damage, really are the things that will drive the management ultimately. So how common of a problem is this? How often do we see it? Quite commonly. So about 5% of pregnancies worldwide definitely has racial ethnic variation, as well as is related to underlying comorbidities. So that explains some of the variation as well. Gestational hypertension can complicate up to 20% of first pregnancies. Between 10 and 20% is usually what we would say. And then less common in multiparous women. So more common in a patient who has had a prior history of a hypertensive disorder of pregnancy or a pre-existing condition like hypertension or diabetes. For a woman who does not have hypertension, diabetes, or autoimmune disease and had a previous pregnancy where she did not have hypertension, the likelihood of preeclampsia is quite low, unless, or usually less than 1%, unless her risk factors have changed significantly. So if her last pregnancy was 20 years ago and now she's 45, that might be different. But if it's sort of within the same time frame and her health status hasn't changed, then the likelihood of that should be low. So risk factors that we think about for preeclampsia: nulliparity, obesity, which we've talked about a little bit, prior history, extremes of age. So young women and older women also can both have a higher likelihood of preeclampsia, multiple gestation. Now we'll talk a little bit about the placenta as the source of preeclampsia. And so the thought is that maybe related to placental mass or placental abnormalities associated with multiple gestation, that makes it more likely. And then, as I said, sort of all of the things that you would think about being associated with vascular compromise. So diabetes, vascular disease, renal disease, autoimmune disease. Intriguingly, smoking is associated with a lower risk of preeclampsia. We're not recommending anyone take up smoking, but it is just an interesting thing because it's one of the few things in medicine that smoking seems to reduce the risk. So why does this happen? Like all of these end organ signs that I talked about, the lab abnormalities, what really is going on pathophysiologically? So all of those clinical manifestations really come from a microangiopathic picture that has to do with systemic endothelial dysfunction. So as I said, these are disorders of pregnancy. You have to have a placenta to develop them, although you don't have to have a fetus. In a molar pregnancy, you can have preeclampsia develop, and in fact, you're more likely to have preeclampsia in a molar pregnancy. And once that placenta is delivered, then preeclampsia will be cured. It doesn't happen immediately, but that is the curative procedure for preeclampsia. After delivery, the symptoms will resolve. As we said, hypertension sometimes can persist, but that may be related to sort of unmasking an underlying predisposition. It's not really that the pathophysiology of preeclampsia continues. There are a number of specific placental pathologic abnormalities that are associated with preeclampsia that basically have to do with vascular invasion and villus maturation. So sort of the way in which the placenta is acting in the oxygen environment, and sort of what it is trying, had the placenta giving it, anthropomorphizing there, what the placenta is trying to do in terms of recruiting more oxygen carrying capacity. So the idea is that these abnormalities of the placental vasculature, and particularly the development of the placental vasculature results in placental underperfusion, and then that really leads to this release of these anti-angiogenic factors. What triggers that initially is really unknown, but some of the preventatives are sort of aimed at trying to prevent that process. And we also know that the signs of maternal inflammation are quite exaggerated in preeclampsia, so it is an inflammatory state for sure. So here's a little bit about the pathophysiology. This is one of Jeff's slides, which is, I like the inclusion of evil humors in here. So we start off and, people do have a predisposition to preeclampsia. So whether it's genetics or their immunology, the environment, which may relate to underlying medical conditions, like the hypertension or diabetes, bad karma, right? Bad luck. We do have patients sometimes who have none of those risk factors who have preeclampsia. That leads to this relative decrease in oxygen, which then leads to this abnormal placentation. Once the placenta is there and is abnormal, then it leads to the release of these soluble factors that may, predispose to endothelial damage and endothelial activation. And so the one that has been posited most frequently is SFLT1. We'll talk a little bit about that, which basically binds to VEGF and leads to endothelial activation, and then that leads to preeclampsia. And as we said, sort of those other predisposing factors may be related to damaging the endothelium and also leading to endothelial activation. Whether they are sort of the same process or different processes is a little bit hard to tell. So is SFLT1 really that evil placental humor? What's the evidence for that? So we know that VEGF in general promotes angiogenesis through its receptor. SFLT is the soluble form of that receptor rather than the transmembranous form. And so SFLT antagonizes both VEGF and placental growth factor by binding them and preventing interactions with their receptors. So what you can see here, if you can see my pointer, is this is a normal pregnancy. And so you can see all of this vessel remodeling that's leading to increased vascular flow here, which allows this, robust blood flow and normal oxygen saturation that then allows that delivery here over to be able to oxygenate. And so when you have those normal levels of these factors, then you have normal endothelial function and the vessels are normal, none of these other downstream consequences. So here you have basically like this idea that you sort of have hypoxia, and then you have this cycle where you have SFLT1 that increases, you don't get any of this vessel remodeling, you lead to this, increase in free VEGF and placental growth factor going down, lead to more endothelial dysfunction, abnormalities in these vessels, and then you end up with this multi-organ disease. So as you can see from this citation, this is quite a theory that has been around for quite some time. And you would think that, then you could be able to test this in terms of trying to figure out if this would be a process that could be interrupted. So the things that we know for sure are that SFLT1 is elevated in preeclampsia, and that removal of SFLT1 in vitro studies does restore normal endothelial function. And so that's really the main evidence for this theory. So what can we do kind of practically in a clinical scenario? So we'll talk a little bit about treatment, screening, prevention, and then long-term health outcomes. So again, here we are in clinic. We're having a hypertensive disorders clinic today because here's a 38-year-old G1P0 at 16 weeks. She's had chronic hypertension since age 28. She hasn't been taking any meds during pregnancy. She has no other medical issues. As I mentioned, she had a baseline 24-hour urine that was done early on because of the chronic hypertension, and that came back with 80 milligrams of proteinuria, so normal since it's under 300, and her creatinine was 0.6, also normal. And then her blood pressure today in the office at 16 weeks is 140/95. So I never sort of told you what we should do with our first patient, but hopefully after my description there, for our first patient who was 37 weeks with a blood pressure of 150/100, no prior hypertension, and also a headache, she's showing signs of severe preeclampsia based on the headache and the elevated blood pressures that are new. And so her curative procedure at 37 weeks would be delivery. Obviously, at 16 weeks, in somebody who's a chronic hypertensive, we're thinking about things quite differently. And so what do we think about that blood pressure of 140/95? What's the best management for that in pregnancy? So this is a question that I think has had a lot of investigation. This is the most robust and most recent evidence, really looking at what's the right target blood pressure for hypertensives in pregnancy. And so these were patients with non-severe, non-proteinuric, either chronic hypertension or gestational hypertension, which is interesting because gestational hypertension in general, we don't treat with medications. And to meet the criteria, they had to have a diastolic blood pressure between 90 and 109 if they were not on meds, or between 85 and 105 if they were on meds. participants. They had a living singleton pregnancy between 14 and 34 weeks, and they were randomized to less tight blood pressure control with a target diastolic blood pressure of 100 versus tight with a target diastolic blood pressure of 85. And the reason why this focused on diastolic blood pressure in particular is that there is some evidence that that might be most predictive of stroke risk in the setting of preeclampsia and hypertension in pregnancy. So what do these women look like? Pretty much like the women we expect to see. So mean age of 34, about 50% obese, about a third nulliparous. 75% of them were pre-existing hypertensives, which I think is important because, as I said, we tend to treat gestational hypertensives quite differently. And about 60% were on an antihypertensive medication at enrollment. The mean blood pressure was 140/92, and they were equally allocated as you would expect in a randomized trial. So what happened? So not surprisingly, those who had the less tight control had higher blood pressures. So they achieved their goals in terms of meeting their treatment goals for blood pressure. But when you looked really at what the downstream consequences were in terms of serious maternal morbidity, severe hypertension, and preeclampsia, the only thing that was significantly changed was severe hypertension, which again, I think goes along with the fact that they were able to meet their blood pressure goals. So fewer people had severe hypertension in the tight controlled group, but they didn't change the incidence of preeclampsia and they didn't change the incidence of serious maternal morbidity. So in terms of preeclampsia, this has been well known. So blood pressure control really is aimed at decreasing complications of elevated blood pressure. It doesn't prevent preeclampsia, and we know that to be true. But the serious maternal morbidity was the question, right? Elevated blood pressures can be dangerous for both mom and baby, and so having a tighter target for your blood pressure control, would that help to reduce the complications? And in this study, it did not. So basically, the idea from that was that probably tight control of blood pressures wasn't necessarily helpful and could potentially be harmful. And so what are the ways that we think about treating chronic hypertension in pregnancy based on this and other evidence? So there are some blood pressures that should be treated for maternal indications. And so that starts off with the severe range blood pressures because we don't want to have a patient have a stroke. So blood pressures greater than 160/110 are treated. And then those with mild chronic hypertension who have other risk factors for having end organ damage related to hypertension should also be treated more aggressively. So anyone with diabetes, again, because of the impact on renal disease and retinopathy, and then those with chronic renal disease of any etiology, again, to be renal protective. But for women with mild chronic hypertension who don't have other medical indications or also mild gestational hypertension, there's really no evidence that treatment improves pregnancy outcome. And like I said, I think that from the obstetric literature in the United States, the fact that we wouldn't treat mild gestational hypertension in particular has been pretty consistent. But this idea that you don't need to tightly control chronic hypertension is something that has changed a little bit over time. The other thing that wasn't from this study, but from other studies, is to say that because of this idea of placental perfusion and sort of what the vascular environment is, it may be that tighter control is associated with growth restriction for the fetus. And so that's another reason not to over control blood pressure in order to maintain that placental perfusion. So we squared that lady away. We're okay with her blood pressures at 16 weeks. We'll continue to follow her. Here's our next patient. 35-year-old G1P0 at 27 weeks. She comes in, she has a headache. She has a severe pressure of 170/115. She has elevated liver function tests. So remember, we talked about 2 times normal as being the threshold for abnormal and severe end organ damage. And her platelets are also under 100,000. Her creatinine is a little bit higher than we would have expected for pregnancy, but not yet meeting the criteria for renal dysfunction. So hypertensive emergencies. So just like with anyone, a blood pressure of 170/115 in a pregnant woman is not something that we want to continue to see. Also remembering that these are patients who in general are not used to seeing blood pressures like this because most of them are young and healthy. So for anyone who has a blood pressure, systolic blood pressure greater than 160 or a diastolic blood pressure of 110, we really want to just confirm that it's a real finding, and then we want to treat it. So depending on where we are, in general, this is something that we would want to transition to the labor floor or an emergency room if that's appropriate in the institution that you're at. Most frequently, it would be the labor floor. And then we would want to think about treating as quickly as possible. And so guidance would say that we want to treat it as quickly as possible after it's been confirmed, but certainly within 30 minutes. And so labetalol, hydralazine, and nifedipine are our general medications that we would use. Magnesium can be incorporated because that is going to be for seizure prevention, with the idea that this likely is a preeclampsia as a presentation, but it really is not going to control the blood pressure. And so the most important first thing to do is to control the blood pressure. And then depending on the gestational age, this is when we would think about delivery. So this is clearly severe preeclampsia, assuming that there's not another etiology that explains any of this. And we know that at an early gestational age, I think I gave you 27 weeks, at an early gestational age, there is the possibility of expectant management if we're able to safely bring the blood pressures down and there's not other evidence of end organ damage. Her liver function tests are elevated. So unless we have another reason for that, that would be a contraindication potentially to expectant management. But anytime that we're thinking about expectant management, we know that we are taking on maternal risk in order to hopefully obtain fetal benefit. And so always at any gestational age, the safest thing for the mom is to be delivered. And so if we're thinking about expectant management, we want to have a careful conversation about the risks that incurs both for the mom and then also for the fetal risk of intrauterine fetal demise and abruption. So important to have a shared decision-making conversation around that. So how are we going to treat that acute hypertension? So this is from the most recent Gestational Hypertension and Preeclampsia ACOG Practice Bulletin. And so really looks at these 3 different medications. I think that outside of obstetrics, I don't think nifedipine immediate release is really used very frequently. Our particular population can tolerate that medication a little bit better. I would say that that usually is only used if you have somebody who does not have IV access, because our preference would be for labetalol or hydralazine. And so, depending on their pre-existing medical conditions, other things, comfort with these medications, you could start with either the labetalol or the hydralazine. Both of those are effective medications, and you just have to keep an eye on what the maximum doses are. So we talked a little bit about S-split. And so if we're in this tough situation where we have this 27-weeker and she has severe preeclampsia and her liver function tests are abnormal, if S-split works in vitro, can it work in somebody who has preeclampsia? Could you give a patient like this some kind of treatment to try and remove that S-split, and would it work? So this is the study that was done now quite a while ago by Ravi Tadani, who had left and come back, and as well as some collaborators from across town. And so basically with 8 women, this was done in Europe, all with preterm preeclampsia, they did use apheresis to basically try to remove that S-split. And so what they were able to show was that they were able to bring those levels down. And then that with that decrease in the S-split levels, they also were able to, affect kind of the trajectory of the protein to creatinine ratio and also the blood pressures. And so they were able to get, you can see, some pretty significant expectant management in this group. I think that they acknowledge that it is hard to know whether this is applicable to a broader population, and this really was a pilot study. This has not become a part of routine care for preeclampsia, but is something interesting just to think about and sort of proof of concept of the involvement of S-split. So now it's Friday, it's 4:45, and still we are having all these hypertensive folks. This is one of your new OBs at 10 weeks. And she comes in, she's 37, she's a G1P0 at 10 weeks. And she says, I searched PubMed for pregnancy complications and read all about preeclampsia. Do you think I'm going to get it? And is there any test I can do to find out? So I think that, as anyone who takes care of women who has these complications, of course, if we don't know that we have an effective treatment beyond delivery, one of the things we want to think about is there any way that we can predict or prevent this? So the first trimester risk assessment for preeclampsia is something that has been investigated. There are a couple of different risk prediction models that can be used. They relate mostly to placental analytes, other characteristics of the mom in terms of risk factors and prior history, and then finally assessment of the uterine artery Doppler. So none of the various predictive algorithms are predictive enough for them to make a difference in terms of management. So we'll talk a little bit about some of the prevention strategies that are out there, but basically we would not use any of these risk prediction algorithms in order to guide the use of those preventative strategies. I'm sorry, my light just turned off. Now it's going to turn back on. And look, I had fancy animation in there that I didn't even know. So the main thing that we would say is just to take a detailed history, and then as I'll show you, there is some preventative work that we can do. So this is from the USPTF, really looking at low-dose aspirin for the prevention of complications from preeclampsia. And so basically what the recommendation is to use low-dose aspirin as a preventative medication started after 12 weeks of gestation, but as early as 12 weeks is optimal. And then that helps to reduce the likelihood of preeclampsia. And so what are the risk factors? Who are the people that might be helped by this intervention? So this is the set of clinical risk factors. So the high risk is history of preeclampsia, particularly when they had an adverse outcome associated with that, multi-fetal gestation, as we talked about, chronic hypertension, diabetes, renal disease, or autoimmune disease. And for any of those indications, we would do low-dose aspirin. Secondly, we have moderate risk factors. And so these you would more think about giving aspirin if you had multiple. So nulliparity, obesity, family history of preeclampsia in a mother or a sister, sociodemographics, including low SES and African American race, age over 35, and then also other personal history factors. So not preeclampsia necessarily, but previous adverse pregnancy outcome, long interval between pregnancies, as we talked about. And then the only patients that you wouldn't necessarily use aspirin in would be those who really didn't have any risk factors, either in their own history or in their prior pregnancy history. And so what should you do? What's the dose? What's the timing? So this is one of the studies. There are many, many studies of aspirin for preeclampsia prevention, but this was a randomized trial of 150 milligrams each day versus placebo for women at high risk, who were defined in a variety of ways, but did incorporate some of the placental analytes and Doppler studies that we were talking about. It was started between 11 and 14 weeks and was continued until 36 weeks. There was a little bit of an interesting signal related to potential for timing of administration having more efficacy, and basically showed just a small risk reduction in the likelihood of preeclampsia based on this intervention. So like I said, this is one of many, many studies. There's now an abundance of evidence looking at this in terms of the pathophysiology. Really, the pathophysiology seems to be related to that early placental development, which is the reason why it starts at 12 weeks, and changing the balance, as you would expect, between prostacyclin and thromboxane A2 to really try to have the vascular development and villus maturation in the placenta to be more normal. So that's the theory, and that sort of goes along with the idea that really having a placenta that's well perfused with a normal oxygen environment is the best way to prevent preeclampsia from developing, because the absence of that seems to be associated with these abnormalities. So now we're seeing back that 35-year-old that we delivered a little bit before. And now, rather than being in my OB clinic, she sees you as her PCP. So she talks about her delivery history, and she talks about her preeclampsia and how scary that was. And then she says, my blood pressure was only high when I was pregnant, and I'm never doing that again. So that we don't have to worry about that anymore. So that's the next question. When we think about what are the things that cardiologists and PCPs and other medical practitioners might think about, why does it matter if your patient had preeclampsia when she was pregnant? So, all different pregnancy complications really are associated with later maternal health outcomes. And we can think of pregnancy as a stress test or sort of window on future maternal health in lots of ways. So we know that gestational diabetes, for example, predicts later type 2 diabetes, incidence of up to 40%. But we also know that there are interventions that we can offer after delivery that can change that. So lifestyle changes, decreasing, weight gain in between pregnancies or weight gain after pregnancy, returning to pre-pregnancy weight. And then metformin also has been shown to decrease that likelihood. And so the question is, what about preeclampsia? Does preeclampsia or any of these hypertensive disorders of pregnancy predict later cardiovascular disease? And if it does, is there anything we can do about it? So there are lots of different studies also looking at this. This is one of the ones that came from a retrospective cohort from Florida. And so they sort of combined a bunch of different pregnancy-related risk factors into something that they called Placental Syndrome, which included preeclampsia, eclampsia, gestational hypertension, and then also placental infarction and abruption. And so we know that women who have one of these complications in one pregnancy can definitely be at risk for the others in a subsequent pregnancy. But when we look at them all together, what's the likelihood of other future medical complications? So their outcome was composite cardiovascular events, and looked basically at about 265,000 women who did not have placental syndrome, 36,000 who did. They were about 25 years old at entry, and the mean follow-up was 4.8 years, which is really interesting. And also, if you look at the whole thing, 1998 to 2009, when you see the results, I think it's really interesting to see what they found. So basically, if you can see from these different curves, this right here is someone who had no placental syndrome, no small for gestational age, no preterm birth. And then basically, as we go to all of these different lines, the red one here is placental syndrome and also had small for gestational age and preterm birth. So kind of, showed that there was both a maternal and a fetal effect of whatever this hypertensive disorder was. And so you can see that really the likelihood of cardiovascular disease was significantly increased. And this is among this group of women who was 25 on average at entry and are only being followed for a mean of 5 years. So even in that small time period, you can really see this signal of saying that the likelihood of developing some of these complications is much higher. So there's been a lot of different studies on this, as I said. So this is a systematic review and meta-analysis that was back from 2007. I always like to point out that this was a medical student who was the first author. How cool is that? And so basically, like I said, this slide is very busy, but what you can see over here is that really the signal is quite strong of an increased risk of hypertension in those women who had preeclampsia in comparison to those who did not. This is from that same paper in 2007, and so looking at MI in particular. So same thing, while the number of cases overall is fewer for MI than hypertension, really can see this strong signal to say that there is an increase in the risk overall with a relative risk of around 2. So this, looking at longer term outcomes again, was looking kind of at the whole conglomeration of things and trying also to understand, does this seem that it is all-cause morbidity and other complications as well, or is it really focused on cardiovascular morbidity? And really showed that it does seem to be associated with overall mortality, but through the mechanism of cardiovascular morbidity. So after an average of about 15 years, increased incidence of stroke, VTE, and overall mortality, but no change in cancer. And so just saying that this is overall a marker for sort of poor medical outcome, but really is related to the specifics of ischemic heart disease, stroke, VTE. And they also saw that there was an increased risk with early onset or severe preeclampsia. So it did appear that the particular, the severity of the preeclampsia presentation did make a difference as well. And along those lines, if you had, in this later study from 2018, really showed that if you had multiple pregnancies that had hypertension, that also further increased your risk. So remember I said that for a woman who's had a prior uncomplicated pregnancy, the likelihood of any hypertensive disorder in the next pregnancy is quite low, less than 1%, unless the personal characteristics have changed significantly. Even for recurrent preeclampsia, so the likelihood of recurrence of preeclampsia varies based on the gestational age of the presentation, and then also whether it was severe preeclampsia or not, and also these other risk factors. But still, there are many people who do not have preeclampsia in a subsequent pregnancy. And even with the most severe early onset preeclampsia in a prior pregnancy, the recurrence risk is probably only around 50%. So for those women who unfortunately have these disorders more than once, definitely a further increase in the risk of hypertension, ischemic heart disease, and CVA. So this is an even more recent study. This is just from May of 2020. That is from the Journal of the American College of Cardiology. And so again, sort of in a nice graphic way, showing with hypertensive disorders of pregnancy, first of all, a sort of overall signal for hypertensive disorders of pregnancy, and then also preeclampsia, gestational hypertension, and chronic hypertension in terms of the association with other complications. And then also just to say that with each one of those, elevation and likelihood of long-term hypertension, coronary artery disease, and stroke. And so finding both the fact that there is this continued relationship that's described, and then also that if you have multiple pregnancies that are complicated, that risk further increases. So what should we do? So the association between those is pretty clear. The causality isn't really clear, however. So, it could be that, as we said, pregnancy sort of unmasks this underlying predisposition, and the people who are likely to have preeclampsia are the people who would end up with these complications, sort of no matter what happens. But the other possibility is this sort of, reveals this vulnerability, and that there is some way to intervene to be able to reduce that likelihood. And that, of course, is what we hope for anybody who has a condition that may predispose them to to a later adverse outcome. So people have looked at this both from the medicine side and also from the obstetric side. And so thinking about, do we communicate from the OB side to the follow-up to the PCP or cardiologist about this history of preeclampsia? And then is this a group that's followed more closely to try and figure out if they're developing other signs of morbidity or if there are other treatments that would be recommended? So this was from primary care records of about 1,200 postpartum women that had a very small number with a history of preeclampsia. And they did find that in that immediate time postpartum, the first 3 months, the blood pressures were checked more frequently for those with preeclampsia. But after that, really that difference went away. And again, small numbers, but still, some opportunity for improvement there. And then also in thinking about kind of assessment of the other risk factors for cardiovascular disease, didn't see that people were sort of looking for metabolic syndrome or checking glucose or cholesterol. So this task force, actually, the picture up there, this task force booklet has actually been retired now. But this evaluation for risk factors is not something that I've seen published elsewhere, so I sort of retained it here. And so their recommendation was for women with a medical history of preeclampsia who gave birth prior to 37 weeks, or who have a medical history of recurrent preeclampsia, that there should be yearly assessment of blood pressure, lipids, fasting blood glucose, and BMI. And so again, you can see them giving the caveat that we've just been talking about. So there is this clear evidence of the association, but when you need to be looking and when you need to be intervening is really not clear. And so they give this potential checklist of sort of saying, like, here are some questions that as a medical provider you might want to ask that would help you to figure out whether a woman has had any of these complications. Now, obviously, visits are short, and this is a lot of questions that would focus on pregnancy. So I don't know that all of these are things that can be incorporated into routine PCP care, but just something to think about. And also, I think on our side that we should be communicating more clearly to people who are doing a follow-up. So just, an investigation of that. This is a study that came from the Brigham here that really was looking at, in our medical record, were you able to kind of find whether we were doing cardiometabolic assessments for women who had a history of preeclampsia. And what they found was that basically the OBGYNs were really good at putting the preeclampsia history into the medical record, but they weren't very good at doing the follow-up testing, versus the internists were less likely to put the pregnancy history into the medical record, but if it was there, they were much more likely to act on it and do the testing that we needed. So I think that the most important thing is that we need each other and we need to learn from each other to figure out what are the right things to do. I will say this group did a very good job in terms of the internists. The fact that 75% of them were asking for a pregnancy history certainly is impressive. I don't know that every group would have done quite as well. And so one opportunity to think about, I think, particularly for the population of people who are in this room, people who are interested in women's health, interested in thinking about these questions and the way that health during pregnancy can be informative for health later on, is to think about collaborative options. And so this is a maternal health clinic, which basically is looking at people who have these pregnancy complications and getting them into a follow-up clinic where they really would be able to have those risk factors addressed. And there are all sorts of ways to think about this, both as something that starts during pregnancy and then also something that is a referral base in the postpartum period. So just things to think about as we think about collaborative care models. So what have we learned today? What am I hoping are going to be the take-home points from all of this? So hopefully we have a good definition of preeclampsia. Understand that this is a disease of endothelial dysfunction and maybe results from angiogenic imbalance. We know that preeclampsia identifies a group that's at increased risk for later cardiovascular disease and also diabetes and renal disease. Those risk factors may be associated with both preeclampsia and cardiovascular disease. And while it's sort of unclear if preeclampsia is sort of an independent marker versus really just being related to all these things, preeclampsia usually occurs before those markers are checked. So even if it is that preeclampsia really is just marking, these other abnormalities that are going to appear, if we find the preeclampsia first, it can allow us to do the appropriate follow-up for patients beyond that. And so because of that, a history of preeclampsia may offer an opportunity for intervention to improve women's later health. And so with that, I'd like to thank you for your attention, particularly in this format where I can't see you and know how you were feeling about what we were talking about, and I couldn't ask you my questions about the cases. Like I said, I'll look forward to meeting all of you guys in the question and answer session a little later on. Thank you so much.